Thank you very much, Dr. Padilla. Now, did I hear you say your parents were undocumented? Yes, so now those two things that we match up on. And Dr. Rios, are there any questions for the panelists? Well, if you thought of a question, what would that question be? There's one. Go ahead.
Thank you. Great presentation. But my question is in terms of funding. There just seems to be a precarious situation in terms of whether or not the funding is going to continue at the rate it has been, or if it's going to be cut. Today there was a threat that the president wasn't going to sign
The president has signed it. Does somebody want to come and take this? Yeah, go ahead.
Yeah, I just checked. He did sign, but or said he was going to sign. The NIH is a significant part of the research, the major actually investment in research. Our institute is small. We don't conduct the majority of the minority health disparities research done at NIH, although I would say the overwhelming majority, almost all of our funding goes for these topics, as you might expect. But I think that you have to look at across the entire agency where funding is available. We're going through a process of sort of recategorizing our coding of our grants to try to, internally at least, think about what we call research in minority health disparities, so the scientific projects. And I went through quickly on the strategic plan, but then there's a research sustaining categories, which we call inclusion or diversity or capacity building. And these are different because the science of minority health disparities really is something that in the last 15, 20 years before our institute was founded as a center, it was an office in the director's office until 2000, really was not very clear what it meant. Most people thought it meant access or only social determinants. And I think as we have learned over these last couple of decades and longer, because research has been going on before for many years, it's complex and there are so significant discovery to be made in having research in minority populations, as well as understanding pathways. So I'm optimistic that this will continue to be the case. NCI, heart, lung, and blood, diabetes, digestive diseases, kidney disease, all support minority health and health disparities, drug abuse, alcohol. There are people, and aging and child health, there are people at each of the institutes that are sort of oversee that or represent that. And so I think that that's on those topics. And for minority scientists, it's a wide open, you can apply. And funding is a challenge. In NIH, it's, peer review grants, and so you have to do the best you can and make it through peer review. There is a strong effort at NIH now to support more early stage investigators. And so we're trying to make sure that people don't get funded just because they've always been funded or they're very well established and everybody thinks, oh yeah, they've got a great grant because they were well known. And those are challenges that we can make a difference on our side by deciding who gets funded on not just on the score of the grant, but using other factors as well. You have to be scored and you have to have a good score. But the idea that, if you're below a certain cut point, you don't get funding is not the case for many institutes, including ours. So it depends on the topic? Is it part of our priorities, our agenda, about the PI? I'm not interested in giving someone their fourth R1, for example, or they already have 3 big grants. Why should they get another one? Versus someone who is early stage or has had 1 grant but is now trying to get a second one. And so I think that these are all complicated factors. But each of the last 3 years, NIH has received a significant increase. I think this one is the biggest one since I've been here, for us anyway, as a NIMHD. We get the overall proportion increase. There are topics that have been much more funded by Congress. Alzheimer's disease has just been an incredible boom. Aging now has, I don't know, close to $1 billion dedicated just to Alzheimer's. So if you're not sure what area you want to research, maybe that's a good one. And there's much need to do minority health, health disparities in that area. There's a lot of not known factors there. I was funded by NIA before I came to NIH, so I know that institute pretty well. Opioids are obviously a hot topic, and I think there's somewhere around $500 million in this year's budget, and the one that just got approved, to do opioid research. Some of it going for this fiscal year, some of it for next year, and they're giving it a 2-year lease, so you don't have to spend it all now. NIH directors have been busy thinking about, well, what can we do? What can we do? So you kind of anticipated this, and the money is going to go to NIDA and to NINDS, the Neurological Institute and the Drug Abuse Institute. But it will easily get, the director has the authority to transfer it anywhere. And I didn't talk about opioids before, but I don't know if it's on the agenda for this meeting, but one of the interesting things about opioids has been that the burden of the overdose epidemic has been among poor whites, primarily, particularly rural-based or suburban, not in the big urban centers, and also the American Indian population. They have suffered a disproportionate burden of the opioid epidemic. African Americans and Latinos, interestingly enough, there's some alarming increases in the last year or two, but the overdose use rate for either prescription opioids or heroin have been substantially below that for whites. And the common explanation is, oh, Latinos and blacks don't get prescription opioids because there's biases from the doctors. And you actually there's not very much empirical evidence to support that premise. There's 2 studies, both in emergency department, nothing in primary care, which is where, the sustaining action happens. You can get Vicodin in the emergency room, but someone else has got to pick up the prescription after your emergency room visit. And then there's a recent study showing that the overdose deaths among blacks from cocaine was actually exceeded that of opioids, and is the #1 cause of overdose deaths, both among African American men and women. And no one's talking about that. Everyone's talking about the opioid overdose. So I think it's an opportunity to leverage the new funding to do more in that. The cancer moonshot continues, and I think there is a disparities component of that. So I think if you're at all involved with cancer risks, I think that's an area that will continue to receive robust funding. The other big topic is the All of Us program. I think it was earlier, Elena referred to it, the 1 million-person cohort. They were having a meeting, workshop, Wednesday, Thursday, and today. It ended at noon today, or early this afternoon. And the goal here is to recruit 1 million people. So that sounds pretty daunting. There's money in the budget for 10 years to support this. The director is an exciting, really wonderful guy named Eric Dishman, who's a cancer survivor, came out of Intel. He's not a scientist. He did work with elderly people in home care. He's a social scientist background. but very facile with organizations in technology. And it's a big task, and we need people to sign up. Now, one of the federal qualified health centers, which they gave grants to 6, one of them is in San Isidro in San Diego, that Greg Talavera is the director of research there. So he's linked to NHMA. So it's a major push. They haven't yet rolled out nationally, officially yet, but it's coming this spring. And I think they've been doing all the beta testing with their recruitment stuff. And when that study is available, that's a public access data. It's not going to be the investigators' data to finish and analyzing before. It's actually anyone can, well, I'm sure there'll be a process to access the data. And I also want to put a plug in for the SOUL study, the study on Latinos, or the Hispanic Community Health Study. 16,000 Latinos were recruited. Dominicans, Puerto Ricans, Cubans, Mexicans, Central Americans, and then a sprinkle of the rest of Latin America. But the 5 major national origin groups are well represented, 4 field sites. It's a wonderful data set. You want to write a paper off of it, you put in a proposal, they review it, they approve it, and you have 2 years to get your paper at least submitted. And it's NHLBI funded, so it's focused on cardiovascular health, but it'll have everything in it. And they've had 2 visits. The visit 2 data, I don't think quite have been released yet, but they soon will be. And they have about, I think it's about an 80% retention on visit 2. And they will be funding a visit 3 as well. So this is a terrific data set that well worth an NIH investment. We have co-funded it in the past, and we'll co-fund it in the future, as well as to look at, you can have a question. You say, I want to do an ancillary study, and I get funding for it. And then you can do the additional data collection. And the idea that NHLBI has for these cohorts is to create a framework where they support the field sites to do the data collection and maintenance and keep all the data clean and all that stuff. And then investigators will write grants to do the science, not to have the field sites do all the research. I think that's the direction that they're moving. So I'll stop with that. Thank you.
I have a question.